Good morning and welcome to the third annual Faces of PAD 2020 virtual program. On behalf of the Vascular Institute of Chattanooga, I am Christopher Lassar. I'm a vascular surgeon in Chattanooga, Tennessee, and my partners William Harris and Elizabeth Hartman and Daniel Kraselek will be acting as moderators for 8 sessions during this virtual course. Through the Tennessee Medical Association, this activity has been accredited for 7.5 hours of CME for viewing this. And my many thanks to our lead sponsor, Bard, and our platinum sponsors, Gore and Phillips, for financially supporting this program so that the credit hours are free to our 330 participants in this program. Our participants are ranging from the Tennessee Valley all the way to Alabama, Mississippi. We have folks from Texas and from the West Coast, Oregon and Washington, and all the way up to Michigan. So we really have a good collection of people from all over the country that are viewing this event. Additionally, and last but not least, I couldn't fail to mention our mates from Australia and Sydney, and that also have signed up for this program. So PAD is often unrecognized, undiagnosed, and undertreated, and this can lead to devastating consequences with the undermanagement of medical risk factors. And so many of the physicians today are going to talk about the end stage process that we are experiencing, what we have to treat every day for these patients. And so with an all-star cast, really from in our presenter sections, we have nationally and internationally renowned people that are involved with this conference, and we're very excited to get this kicked off. A few housekeeping functions. The QA function is important for our participants in the general. If you have general questions, the moderators will be answering many of those back to you directly. We do want this as interactive as possible, so please consider that. Now, as far as the chat function, if there are more specific questions to a specific speaker, please use that as your mechanism to engage that speaker, and they'll either answer or the moderators will assist with that. Please remember your credit. I mean, if you're going to invest in the time, understand that 7.5 hours are available to you, and through the emails, there'll be explanation on how to gain that credit. Also note that this is being recorded, and so through the Vascular Institute of Chattanooga YouTube channel, this will be visualized or be allowed to be visualized again in about 1 week, where you can still finish your credit hours if you have to leave, or if you need to gain your credit hours in that fashion. So the same process will continue. So without further ado, I'd like to at least start the program, as the first hour is going to be talking about healthy lifestyles and what are the things that we can do as physicians, as primary care physicians, and people that are on the front lines every day taking care of patients. What do we need to think about to help us take care of these patients better? So the 4 speakers, the first talk will be PAD syndromes, putting it all together. This will be presented by Dr. William Harris. Will Harris is recently joined the Vascular Institute after completing his service in the United States Air Force. He's board certified vascular surgeon and a fellow of the American College of Surgeons. Now, Dr. Mark Wren is a guest speaker to our conference. He's going to talk about scientifically proven healthy habits. And Mark has earned his doctorate degree and master's in public health from Tulane, did many of his externships at Mayo, and is working as rehab facility to promote general health, and is often sought after as a national speaker. Adam Chaunstrey has been dedicated to exercise education and nutrition education for over a decade. He is a weight loss management certified health coach, fitness and sports nutrition, and a lead team member of Nutrition World, a local outfit in Chattanooga that does excellent work. And lastly, Nathan Hargrove will be talking about the proper medical management of CAD and PAD prevention. And this is from a general practitioner approach. He is a board certified internal medicine doctor. He has had his doctorate of osteopathic medicine from Lincoln DeBusk University, which is local to this region, and has completed his residency at University of Tennessee in Chattanooga, and is a member of the American College of Physicians and the Tennessee Osteopathic Medical Association. So for this next session, we'll be leading on with these 4 topics, and we're looking for a good interaction. So please use the chat function and the question and answer function, and let's get this show started.
Good morning. My name is Will Harris. I'm a vascular surgeon at Vascular Institute of Chattanooga. We're really excited to have you here today. We think we're going to have a great discussion, great speakers from all realms, multiple different specialties, and we've got a lot to talk about today regarding peripheral arterial disease, peripheral vascular disease in society. I have nothing to disclose. We'd like to get started today's lecture by talking about peripheral arterial disease essentially as a syndrome. It's got a huge prevalence in the United States. Between 8 and 12 million by 2015 estimates of people in the United States are affected with PAD, and by some estimates by the American Heart Association recently, upwards of 20 million people have peripheral arterial disease. Likewise, acute venous events in the United States are upwards of 600,000 a year, and with COVID, probably are even more, given its hypercoagulable state. And with chronic venous insufficiency, we're starting to see a huge prevalence of that because we're diagnosing it more, and we've developed better algorithms for treatment. The prevalence in the population of greater than 70 is upwards of 30%, and in those with a history of smoking between the ages of 50 and 69. So you should have a high index of suspicion in these populations to look for peripheral arterial disease. And it's a huge burden on society. In 2015, the amount of money that it cost to treat a Medicare beneficiary with peripheral arterial disease versus those without peripheral arterial disease was approximately 7 times more. Now you have to remember that these patients typically have multiple other issues: hypertension, hyperlipidemia, diabetes, things like that. So you're treating them for all those things, but the cost for these patients is substantially more. And you have to remember that those with critical ischemia account for more of the acute costs, or more of the costs, than those with chronic arterial insufficiency for potentially just claudication or something like that. Now, the role of primary care is vital to identifying these patients. You providers see these patients much more frequently than we do. You establish trust with them, you establish relationships with them, you understand their histories, you see if something changes. And those are the patients that you want, and when you see those changes, those are the patients you want to get to us in the most timely fashion. And hopefully today, given everything, we can help give you kind of guides to identify these patients and help us care for them. Because I really think that the primary care setting acts as kind of the quarterback for managing these patients. Who are we looking for in these patients? Peripheral arterial disease typically affects those over the age of 40, and probably more over the age of 60, the ones that we see it most in, although we do have a lot of patients who are 40, 45, 50. We think that it's vastly underdiagnosed in the United States. The CDC estimates that only 1 of 4 Americans actually understand what peripheral arterial disease is. And there are 2 categories of peripheral arterial disease: chronic and acute. We'll talk mostly today about chronic, but remember that chronic limb arterial insufficiency can lead to acute limb disease or acute arterial insufficiency as well. What are the risk factors? Of course, the usual suspects: diabetes, hypertension, hyperlipidemia, chronic kidney disease, and everybody's favorite, cigarette smoking. It's a huge issue. Cardiovascular disease is the leading cause of death in the Western civilization. Between 8 and 12 million, upwards of 20 million people have peripheral arterial disease. And because we're getting better treatment algorithms for people with cardiovascular disease, more people are living, therefore there's an increased prevalence of those with cardiovascular disease in the United States. Remember, heart disease and stroke are two of the leading causes of death in the United States. And all of these are caused by atherosclerotic disease, which also happens to be the number one cause of amputation. So that's the number one cause of peripheral arterial disease, number one cause of amputation, number one cause of death. So atherosclerotic disease is a subminimal accumulation of lipids and fibrous plaque in a lumen, as you all know. Sometimes this can lead to a plaque rupture, which causes an acute event, and sometimes it just develops a slow buildup in the artery, which accumulates and causes chronic total occlusion of a blood vessel. In identifying these patients with peripheral arterial disease, it really does take a village. Every single spectrum of care can identify PAD and help to treat it, help to identify it. The first role in treating this is identification. So you diagnose, find these patients, identify the patients. The earlier you identify them, the better. Once we do identify them, it's all about risk factor modification. Smoking cessation. We can beat a dead horse, but getting rid of the red meats is obviously a good thing. Getting them to drink more red wines, getting them to exercise more. Risk factor modification is huge. And then we also obviously have pharmacologic adjuncts to modify their risk. But the earlier you get them to us, the better they will do. We don't want to get to the point where the patient's foot is unsalvageable. Obviously, we want to identify them as early as possible to maximize their outcome. So what patients are we looking for? The patients with peripheral arterial disease with the most likely to have buildup of calcium and plaque in their vessels are, of course, those with advanced age. We've talked about that already: diabetics and those with chronic kidney disease. And if you look at the numbers of the population, upwards of 20% of Americans will have some form of peripheral arterial disease because of these risk factors. Peripheral arterial disease and coronary artery disease can be talked in the same risk factor type situation. So these patients have the same risk factors for having coronary artery disease that they will have for peripheral arterial disease. Smoking, age over 70, history of diabetes, history of atherosclerotic disease, history of hypertension. So the highest growing population in the United States is the age greater than 85. The prevalence of peripheral arterial disease obviously increases with age. So you should have a high index of suspicion as we see an aging population in the United States, that these patients may have some element of peripheral arterial disease, and you have to have a high index of suspicion to look for it. So again, we use the same risk factor modification in peripheral arterial disease that the American Heart Association and the American College of Cardiology advocate for coronary artery disease: smoking cessation, diet, physical activity, antiplatelet, lipid lower therapy. We have adjuncts like cilostazol for patients who may have claudication. Statin therapy is tremendously important. You'll hear us talk about this quite a bit today. So as from a primary care standpoint, it's really important for you to quarterback these things. And of course, beating the dead horse, smoking cessation. It's one of my favorite pictures. That's an old cigarette machine that was in a casino in Las Vegas. With the increasing prevalence of diabetes, it's also important to look at diabetic feet, have good care for feet, and prevent the patient from getting to the point where they may need an amputation. The incidence of of amputation in diabetics is incredibly high. And once a patient does get a diabetic ulcer, the incidence of amputation is extremely high as well. Upwards of 5 to 24% of cases of diabetic ulcers can lead to amputation. The incidence of diabetes is expected to double worldwide by 2030. And these patients with diabetes have upwards of a 10-fold increased risk for lower extremity amputation compared to those without diabetes. So you have to be very, very vigilant about caring for these patients and watching them for evidence of peripheral arterial disease. Some of the patients with diabetes can have peripheral arterial disease alone with tissue ischemia, but some can have neuropathy and some have a combination of the two. So it's important for you to identify the patients with just neuropathy in wounds or peripheral arterial disease in wounds, but all of them, for the most part, should be evaluated by a vascular provider and make sure they don't have some sort of arterial insufficiency to maximize their healing potential and decrease the risk for a major amputation, if at all possible. There were studies that were performed that showed back in 2005 that if a tremendous number of these patients, greater than 50% of patients, did not have vascular evaluation prior to amputation, and they estimated that if they had had vascular evaluation prior to amputation, over half would have been able to have their limbs saved. It's amazing. And it's so important because the long-term mortality for these patients once they've undergone amputation is just horrendously low. Upwards of 50% of patients after 1 year who receive an above-knee amputation will be dead. And at 5 years, only 22% will be alive. And we've already established that the cost associated with these patients who get amputations is just tremendous. They become a burden on society, a burden on their families. It's awful. Critical limb ischemia, when left untreated, peripheral arterial disease can progress to critical limb ischemia. This is where we're at high risk of amputation. They manifest with rest pain that wakes them up at night, ulceration that won't heal, or gangrene. Acute limb ischemia is a rapid decrease, a rapid progression to those things. Patients who present with critical limb ischemia have a tremendously high mortality. Upwards of 25% in 1 year will be dead. And in 5 years, those who present with critical limb ischemia, more than 60% will have deceased. It's just awful. And so we need to identify these patients early, maximize their potentials for healing to decrease their overall mortality. Now, with the advent of increasing endovascular work, no patient really is ever too sick for an operation. We can revascularize the majority of them in an endovascular fashion and prevent them from undergoing a major surgery and hopefully save their life. So how do you identify these patients? History. Claudication, cramping their calves when they're walking into Walmart, rest pain, tissue ulceration, poor healing wounds. Physical exam is huge. Hairless extremities, non-healing ulcers, absent pulses. And then there are other studies you can do. Ankle-brachial indices, we can do these in our office. Patients of around the one probably don't have significant peripheral arterial disease, although these can be falsely elevated in diabetics because of the hardening of the blood vessels. And then those below an ABI of 0.9 should probably be evaluated by a vascular provider. We want to prevent the patient, if at all possible, from getting to the point where they have wounds that are not salvageable. And so you should have a high index of suspicion and send them for referral for vascular testing in patients with greater than 70 abnormal pedal pulses or a history of smoking. And obviously those with critical limb ischemia, rest pain, tissue loss, get them to us as soon as humanly possible. Computer is moving very slowly. So we want to avoid them getting to this. or to this. Or even further. To this. So thanks very much. There'd be some great discussion today, and I'll touch base with you later.
Good morning. I'm Dr. Mark Wren, and I'm going to talk about some scientifically proven healthy habits. And I like to use a mnemonic to help remember things. And so I'm going to start with something old, something new, something borrowed, and something blue. Well, let me switch to full screen share. So, something old, think back to when my mom always said, get to bed, sleep, go play, exercise, eat your dinner, healthy diet. So something old is actually something new that's been proven that her wisdom was very accurate. Elizabeth Blackburn at the University of California, San Francisco in 2009 did an eloquent study of taking leukocyte telomeres, the end of the DNA that is normally cleaved off with aging. 3 times more telomeres or base pair telomeres are cleaved off with major stressors: death of a spouse, cancer, pandemic, Hurricane Katrina. However, they looked retrospectively back at that same cohort of patients. That shortening was totally negated and was the same as the general population without major stressors if they had adequate sleep, adequate exercise, and healthy diet. So something borrowed. Dr. Randall Bradham let me borrow some of his slides, and I just wanted to thank him virtually and personally. I was a guinea pig for one of his lectures 25 years ago when I was studying for my boards, and he did a nerve conduction demo right there in the front of the lecture hall at Baylor, and I was his guinea pig, and we exchanged emails, and I've shared difficult cases with him for many, many years, and was lucky enough to have him come and lecture at our CME event in recent years. So something borrowed is from Dr. Bradham, and he said when he was a resident, he was a cocky resident at Ohio State, and his mentor at the time, Ernie Johnson's kind of a legend in our field, and Bradham wrote the textbook of PM&R, or edited it. He said that exercise can help every tissue in the body, and Dr. Bradham said, oh, I thought he was full of it then, and now I believe him. So finally, something blue. Hopefully not. At a vascular conference, the last thing we want is hypoxia in something blue. So we're going to give you a mnemonic on ways to reduce sedentary lifestyles to reduce arterial disease. Sleep, I mentioned, the S for sedentary, E for exercise, D for diet, E for emotional health. And emotional health is more than just simply taking a medication. It may be laughter. Laughter has been shown to induce T-cell function, lower catecholamines, improve well-being in ways that are very significant. Nutrition, that's going to be talked about in some other lectures. Treadmill exercise is much more protected and easier to control. And then A for activity minimum. There are some studies that show that very clearly and scientifically that a minimum amount of activity may be adequate for reducing cardiovascular disease. Not necessarily as much as an aerobic, but very significant. And then R is what I call realistic tobacco cessation plan. I say realistic because many of us have had patients that we tried and would not quit. And so I've kind of broken my spiel down into ways that I think are more appropriate for each individual. Take the temperature of the room, see where they are with it. But one thing that I learned from one of my family practice colleagues was offer it as a gift that you would say, I'm going to quit for your birthday, for example. And then why you alone control your activity. So exercise has countless benefits. Increase in coronary artery size reduces heart attacks. It improves cardiac efficiency. It has obviously good effects on lipids and blood sugars. It reduces catecholamines and, of course, can lower blood pressure. This is a recent photo of me, front and back, proving that I do exercise. That is directly from Dr. Bradham. So exercise makes you smarter. How does it do that? Well, it improves neurotransmitters. It improves capillary flow. It improves astrocytes, which are support. It improves synapses. So it actually helps new brain tissue develop in important areas like the hippocampus, very important in memory. So it also reduces atrophy. Exercise stimulates a protein called noggin, which is easy to remember, NOG, which signals the brain to produce more brain cells. So there's some threes that I like to remember for exercise. A minimum of 3 times a week. And there are studies that show that more than 3 times a week is not a big benefit. A minimum of 30 minutes. There's not a big jump at 60 of moderate intensity exercise. Claudication up to 3 to 5 minutes is important for patients that have claudication pain to take them to that tolerable limit. And then a minimum of 3 months duration to see a significant benefit. And kind of the best article on that, and I think that's available. I'm happy to email it to you, from the scientific statement from the American Academy of the American Heart Association. So this is a fascinating pearl from Dr. Bradham. Exercise in one limb strengthens the opposite limb. So patients in this particular study with multiple sclerosis, they exercised the better side and it resulted in equal strengthening of the opposite, more affected side. So how is this practical? Well, I have patients with radiculopathy, with severe arthritis in one side, with paraparesis, and they can actually do arm ergometer and have benefit more generalized fashion. The benefit of strengthening is immediate, strengthening exercise. So exercise that's focused on strength is not altering muscle hypertrophy immediately. It's altering what's called the internuncial pool, the number of neurons that are recruited to fire down the anterior horn cell and contract the muscle. So that is immediate. It doesn't change the morphological characteristic of the muscle. Now that does happen down the line, and actually up to 40% in growth even in middle-aged patients. I mentioned to patients repeatedly 6 weeks of exercise in one study of all 90-year-olds showed a 50% increase in quadricep strength. 50% increase in quadricep strength is the difference from getting out of a chair and falling out of a chair. So not only can exercise help function, it helps quality of life. And so function is a big focus in physical medicine rehabilitation. There's not a single medicine that's a better treatment than exercise. It'd be $1 billion if you could bottle it. The American College of Cardiology in 2016 showed an almost 60% reduction in cardiovascular disease in there. So remember, avoiding sedentary can simply mean more active. As you can see that this gentleman is just doing some activity. I've got a free gift card for the first email reply on who coined aerobic exercise. And we're going to do a little demonstration of 50% lower cardiovascular risk with exercise after this cartoon. To exercise or not to exercise? What fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? I think that's perfect. So let me escape here and stop sharing that. And I want to show you a little demo. I have a 50-cent piece. And the 50-cent piece is here to demonstrate that how much reduction in cardiovascular risk can we do just by waving our fingers over it. Just one simple thing. 49%. Thank you for your attention.
Hello, everyone. My name is Adam Chauncey, certified health coach in Nutrition World of Chattanooga. I run our weight loss clinic here with my co-owner and health coach, Katie Coleman. We have been a staple of health and wellness in the Chattanooga area in North Georgia for over 41 years, and I am so grateful to have this opportunity to speak about the benefits of nutritional supplements and supplementation for our patients and clients suffering from this awful disease known as PAD. Now, to begin, I'll offer my disclaimer. I am not a doctor, nor do I pretend to be. I offer all the following information strictly as educational material to hopefully be used by the medical professionals attending these seminars for the benefit of our clients and patients. Now, my goal as a health coach in Nutrition World is to aid our doctors, regardless of their background or training, in the pursuit of better patient outcomes. As I'm sure you will agree, it's all for them, as it should be. Now, lastly, I do sell supplements in Nutrition World. However, I receive no kickbacks, nor do any of us at the store. I'm a health coach, and I do offer supplemental recommendations and nutritional therapies when called for. Now, my goal is to lend a hand to practitioners such as yourselves in the way of congruent or alternative therapeutics for our patients and clients who are not only gripped by this terrible state of disease, but who are also at high risk. Now, I'll be speaking on topics of what I and many researchers, doctors and clinicians alike, believe is one of, if not the most attributable causality to modern chronic disease, insulin and metabolic dysfunction. Now, along with this, I'll also, state my approach to improve insulin sensitivity and the helpful supplements, both in regards to prevention as well as conjunctives for your standards of care. Now, I think most of us would agree that metabolic dysfunction is on the rise, if not out of control in our country. And of course, this is fairly obvious due to many factors, but those are not some of those, and this is certainly not the only ones, but include where the U.S. population, is now has been at epidemic levels with diabetes. We're now upwards of 40% of U.S. adults have clinical type 2 diabetes. Heart disease diagnosis is on the rise with greater than 50 or upwards of 50% of U.S. adults having high blood pressure. Chronic disease states in general are on the rise as well. And my personal favorite terrifying statistic for some added shock value is the fact that only 12% of U.S. adults are actually metabolically healthy, meaning that 80 to 88% of U.S. adults have some form of insulin resistance. Now, in light of that, I'll start with my protocols or, how I approach my clients for prevention and even to some extent when they're in the early stages. Now, there are two things that all these chronic disease states have in common, and one is they all lead to some form of vascular disease, as all of you are well aware, especially PAD. But two, they all have roots in insulin resistance. Now, this begs the question, what can we do better to address this earlier? Now, my personal approach when I see a client for the first time and measure their body fat and other metabolic markers is to refer them out for an insulin test. Before even having the results in and speaking with their doctors, I can tell 9 times out of 10 that if someone is going to be insulin resistant simply by seeing their visceral body fat level. Now, this is a key indicator of poor metabolic health, as you all know. And it's also a, preliminary marker for vascular disease. Now, the difference in my approach versus many others in our fields is testing for insulin instead of just a simple, blood sugar, glucose, or HbA1c screening. Though these do have medical significance, admittedly, it is insulin that acts as the proverbial canary in the coal mine, showing suboptimal numbers in some cases 5-10 years or more before glucose or HbA1c become clinically significant. And this is where some of these nutritional therapies and supplements shine, including functional medicine thoughts, which of course is treating, the whole body and, cleaning it from the inside out and trying to get a jump on the problem, trying to get ahead of the curve. Now, once I have spoken with the client's physician and we have established their risks, I begin a nutritional protocol based on their individual needs. Now, very frequently, this involves some form of time-restricted eating, like a 16-8, or at the very least a 12-12, which is simply 12 hours of fasting, 12 hours of eating, or 16 hours of fasting, 8 hours of eating. This can also play into a low inflammatory diet, which is the other half of the protocol I usually give. Now, this can mean low carb, an ancestral diet based on their genetics, a paleo diet based around whole foods, very clean, low sugar foods, including low sugar fruits, very high quality meats, grass fed, pasture raised, eggs, grass fed beef, heritage pork, cold water fish, wild caught, never farm raised anything, and many other approaches. The goal here is to reduce whole body inflammation and thus reduce inflammatory reactions in the body, which, as I stated earlier, I was going to get to some of the other highly notable predictors of PAD, which is your CRP reading and your fibrinogen content, as well as all the other metabolic morbidities. Now, along with proper food recommendations, I generally piggyback supplements such as berberine, shown to be as effective at boosting AMPK and helping with sensitizing the body to insulin as metformin, or helping the body overcome insulin resistance as metformin in clinical trials. And these also tend to have much less side effects. Not only is it performing as well as metformin, but it's also a powerful tool for dyslipidemia. I also recommend chelated magnesium for artery health and elasticity and insulin sensitivity. I recommend omega-3s, high quality, of course, for their use in triglyceride reduction, as well as insulin sensitivity. Every cell of the body has a receptor site for omega-3s, and the FDA recently just approved a new drug proving how effective omega-3s are, because it is a synthetic version of omega-3s for reducing triglycerides. Now, another product I love recommending is a product called AMLA. It's AMLA, or Indian gooseberry. Now, that's for its use in protecting and raising HDL, helping protect the large particle fluffy LDL, while showing clinically significant reduction in small dense LDL and triglycerides. I also recommend vitamin D to help fight, the low LDL and poor hormone production that's so present in those taking statins long term, and most cardiovascular patients in general. I also recommend vitamin K2 in the form of MK7, which helps aid the body in reading calcium out of soft tissues, such as vascular tissue, and relocating it to bone, with the help of vitamin D and magnesium. It's also notable that proper levels of vitamin K2 are necessary for proper function of the endothelial lining of blood vessels, the lumen. Now, of note, for aiding in the reduction of some high-level indicators of the presence of PAD are the supplements nattokinase and anti-inflammatories such as curcumin, boswellia containing boswellic acid, and ginger. Now, nattokinase, or natto for short, is a nutrient extracted from the bacteria fermented soy, found in soybeans. Now, the Japanese have known about the healing and protective powers of fermented soy for thousands of years. Now, what makes this product have so much potential for those affected by not just PAD, but for its close relative CVD, is its ability to reduce fibrinogen in the blood. And curcumin, ginger, and boswellia have all been in the news so much over the last few years. These anti-inflammatories act as COX-2 inhibitors and 5-LOX inhibitors, and modulators that have notable ability, though not fully understood, abilities to reduce CRP levels in blood. Both, now, if warranted by a doctor, the blood work, and the patient, I will also recommend Red-Yeast rice if they're incapable or unwilling to take a statin that has been prescribed. I mention this because statins are so highly prescribed nowadays, and this is becoming a much more relevant topic with cardiovascular disease, vascular disease in general. because of the easily accessible information that clients and patients have, and the fact that many patients come to places like Nutrition World asking us our opinions on this because they're either afraid to ask their doctor or are unsure of how to ask. So, of course, we give them the necessary questions and send them back to their doctor, educated so they can get proper prescription management from their doctors or practitioners. But things such as the number needed to treat of statin drugs being, at best 63 to 1, 63 patients treated in order to prevent one heart attack. The fact that so many patients come, with statin use with pain and inflammation. It's hard sometimes to keep patients on these drugs, and it is clear that statins reduce cholesterol and save patients who are at higher risk from potentially deadly heart attacks. But just to be fair, patients should also be educated on other and in some cases equally effective strategies for reducing their risk without so much danger or discomfort of interactions or side effects. And this isn't just statins. Statins just seems to be the hot topic lately, but it's for so many other therapeutics and interventions. But speaking on statins, one thing we tend to do when we speak with these patients' doctors or practitioners is, talk to them about reduced rice usage, how it has been shown to be highly effective in a multitude of clinical trials due to its levels of monocolin K, which are lower than typical statins, admittedly, but this plant also seems to contain small amounts of many other forms of statins, which may be, in fact, the reason why reduced rice therapy has as much as a 40% lower incidence of patient noncompliance due to myopathy and just overall body pain. Now, I can't move on without also stating the importance of exercise, especially in the presence of clinical PAD. Intermittent claudication, a hallmark of PAD, as well as many other notable morbidities, are highly affected and favorably altered simply with the addition of exercise like yoga, Pilates, aerobic, respiration, activities, just walking, supervised or cautionary anaerobic exercise for those that are, in the throes of the grips of this disease, are all capable of increasing capillary development, blood oxygenation, stress reduction, lipid reduction, insulin reduction, metabolic adaptation, and sleep, which is huge, and sorely underappreciated. It may seem more like a stretch to believe that simple changes like some of the ones I'm stating may stand to make such staggering differences in the lives of those struggling with insulin-induced, disease states, including, obviously, but not limited to, PAD. But I hold no false notions, such as believing that late in the throes of PAD, that dietary shift and supplements alone could save someone, that's about to fall over the edge. However, all of these therapies may not be only used as preventatives, but also as conjunctive therapeutics. Now, even now, there's an ongoing trial with the use of slow-release polyphenols from resveratrol-containing grapeseed extract and quercetin that are being released from balloon catheters to be used as conjunctives in arterial disease treatment. That is why we have wonderful establishments such as our local vascular institute, places that not only save countless lives with patients who are on the brink, but also helping to direct them in proper ways to increase their overall health and quality of life through nutritional therapeutics and supplements. Thereby reducing their need to have to revisit the emergency room knife. What I'm instead saying is that we have the ability to halt the progression and reduce the life-saving intervention therapies needed by addressing the canaries in the coal mine. Looking to recent research pointing at the high incidence of insulin resistance, CRP, fibrinogen, and PAD proves that doing things such as dietary intervention, supplements previously mentioned, detoxing heavy metals, cleaning their water intake, just the faucet, filtering it, and instructing patients to clean up their environments may halt them from ever needing life-saving surgery or drastic medical interventions. I look at it like proper force management, and I'll say this in closing. The state of the government of California recently admitted that, and I'm paraphrasing, that more could have been done to improve proper force management to help reduce the devastating wildfires of the past few years. This is not so much different than our own bodies. The emergency medical services such as surgery, stents, etc. are fully necessary because many facts, including but not limited to longer lifespan, environmental dangers and toxins, stressors, and so many more. However, properly clearing the undergrowth, if you will, drastically reduces the strain on the fire department when a fire breaks out. What I'm saying is, in so many words, that it is easier to contain a fire that hits a properly managed forest rather than fighting a wildfire that ravages a forest blanketed in years of undergrowth and neglect. It starts with us properly instructing and teaching our patients, clients, friends, and family. It's all about teaching them how to live their best and healthiest lifestyles. I mean, simply put, and that will help lessen the chance of these fires erupting and spreading and engulfing. This way, not if, but when they do, need the advanced therapeutics and interventional therapies, they will be much more likely to survive and thrive. So I want to thank everybody for listening, tuning in. I'm still trying to get used to this whole new thing with the Zoom calls and the recording, but I hope this was informative. And please, if anyone has any questions or wants to reach out to me, my email is Adam, ADAM, @nutritionw.com. Contact information will be in the notes. And if there's anything I can do to help, please reach out. Look forward to hearing everyone else's videos. And thank you very much for your time.
Good morning. My name is Nathan Hartgrove. I'm an internal medicine physician here in Chattanooga, and I'm very happy to bring you my talk entitled Proper Medical Management for PAD. I've got 52 slides and 12 minutes to do it. So here we go. Here's the outline. We're going to focus mainly on the medical therapy options, including the section getting the ball rolling, the who, why, when, and how of treatment. I think it is important to have a good goal in mind, so treatment targets are very helpful. I also want to go through some of the situations where we have conversations with patients and then look at the alternatives to medical therapy. I'm going to be speaking mainly from the primary care setting, since that's what I do. And in primary care, it's important for us to make sure that we are asking really in-tune questions, that we're taking a careful exam, and also following up with the appropriate diagnostic tests, because once patients make it to the inpatient care setting, we start running into a lot of acute events that could be life-threatening or limb-threatening. And also realizing that once they advance to this point in PAD, that can actually be that watershed moment for further complications. And it's also important to know, when do we call on our colleagues for help? So as a multidisciplinary approach, I do think it's important to understand that prevention is huge in the realm of PAD. So addressing risk factors, minimizing at all costs what we can do that actually drives the development of PAD, using exercise as treatment along with some good evidence-based guidelines, and also timely surgery. But after that, making sure that we don't see the subsequent complications with PAD. So the medical therapy options, I do think it's important to understand why we need the medicines, because lifestyle modification is obviously very important, but let's be honest, it's also very inconsistently adopted by our patients. Thankfully, we've got some pretty solid guidelines for treating, and we've had some significant developments in the past couple of years. So with the who, why, and when, and how do we treat, that's going to involve really the evaluation and taking in risk factors. But also we're going to look at the actual agents that we would use. So the who do we treat? According to this 2016 guideline out of circulation from the AHA and ACC, it is important to make sure that we take into account someone's risk factors. We don't want to miss the usual suspects, but we also don't want to just assume that people cannot have PAD just because they don't necessarily fit into one of these categories. So here's just a quick summary of who we would consider to be at risk. You can go back and look at this table later. But basically anyone over 50 with additional risk factors. So a 50-year-old smoker, or a 55-year-old patient with diabetes, or even a 45-year-old patient with diabetes that also smokes. It is important to remember that even asymptomatic patients can have clinically significant peripheral artery disease. There was a study, the Partners PAD program back in 2001, that actually found, when they screened asymptomatic patients, that 29% of those did in fact have PAD. Here's some of the physical exam and history items that you'll get, and I'm sure that these will be elaborated on later on. Also, keeping in mind, we've got a new update from the endocrinologists with their treatment algorithm. A warning, these slides are fairly dense, but they are full of, I think, pretty solid information. This is a thorough evaluation for someone with dyslipidemia, with risk factors for PAD and ASCVD. So this is something, if you're trying to come up with things to check on people, this is one of the ways to do it. But I do think that this is handy just as a very thorough evaluation. So you can go back and look at this slide on your own. The when do we treat? Basically, we've got to ask, our patients symptomatic or asymptomatic? Are they asymptomatic and we just happen to pick them up through screening? Or are these folks that are already having symptoms as a result? But the bottom line is, when you find it, you treat it. It's important to make sure that we reduce the downstream consequences of PAD. And the question is, why? So here's a study out of New England Journal of Medicine back in '92. It was a fairly small study, but graphically, I think it's really helpful to see what happened here. So even though this was a small study, I think it really helps us to see how significant the mortality risk as a result of PAD can be. This is the survival of folks at 2, 4, 6, all the way out to 10 years. And take a look here. So the folks that had any symptoms in large vessel PAD, besides the folks that were asymptomatic and the normal folks, the people that were symptomatic at 6 years, it was a coin flip whether or not they were still going to be alive. So you have to consider these are people that are not just at risk for losing a toe, a digit, or a foot, but these are people that are at risk of losing their lives. So how do we treat? We can look at the 2016 AHA guidelines for this as well. Just a warning, these are going to be kind of dense as well, but take it from me, anything with green and dark blue is good. So first of all, aspirin and Plavix. It kind of goes without saying, this has been the treatment of choice for quite a while. It's got good evidence behind it. The question of treating patients who are actually asymptomatic with dual antiplatelet therapy is maybe a little bit weaker, but often done, and for good reason. With statins, let's face it, it seems like pretty much everyone should be on a statin. And here's why. So when we look at some objective measurements, this is checking simvastatin against placebo and the distance that someone was able to walk, and also the intensity of leg pain. The bottom line is, as we go up here in the distance, people were able to walk farther when they were taking simvastatin, and they were able to have less leg pain. So this helps us in our conversations with patients as we go. Also, the use of ACE inhibitors, ARBs, is strongly backed up. And then in terms of symptomatic treatment, silostazol, pentoxiflin, this does get used, but it's usually a more of a third line, fourth line, and to help with symptoms. And silostazol is not always very well tolerated. I'll skip over this one. It's about homocysteine. Here's, I think, a very helpful slide from Dr. Eberhardt, delivered back in 2013. This is showing, with these different pretty significant trials going back from the mid-90s to the early 2000s, what kind of benefit we were expected to get from these different agents. So aspirin and Plavix, ramipril study in this one, simvastatin in this one, with some significant improvement in events or complications. Furthermore, looking at anticoagulation, according to the 2016 guidelines, not supposed to do it because it causes harm. Keeping in mind what they're talking about is warfarin. As of now, as of May of 2020, with the COMPASS trial, that did change when they looked at rivaroxaban plus aspirin versus aspirin alone. And so what we see here is a pretty quick difference in that first year between the group that was on both rivaroxaban or Xarelto and aspirin. And they maintained that distance as they went, and separated even further from the aspirin alone group. Obviously, we want a decrease in events, which this is very important, but we also have to weigh it against the risk of bleeding. Furthermore, when we're looking at lipids, obviously statins, incredibly important. If you look at the slide set, I've got some further notes about this, but they're readily available, affordable, and they're predictable. We know what high intensity statins are going to do with rosuvastatin and atorvastatin, but not everybody likes them. PCSK9 inhibitors, some of the new kids on the block, Praluent and Repatha. These are some of my favorite medicines to use right now. They are insanely effective and very well tolerated as long as someone can give themselves a shot every 2 weeks. The availability is one of the downsides to these, as their cost is still pretty high. One of the newer ones as well, just a new class in general, ACL inhibitor, bempedoic acid belongs to this group. It keeps us from synthesizing LDL further upstream from HMG-CoA. And so this is also very well tolerated. They do have a combination with Zetia, which performs pretty well according to the research. And then the other groups. So we've got Zetia, we've got Welchol, and what I call the JV squad, some of these older agents that patients prefer to take just because they consider them to be safer. They are very well tolerated, but they're probably not going to be as efficacious. Also need to add in here Vascepa, one of the fish oil products, when combined with statin, does have some pretty good evidence behind that. Furthermore, I bring this up because this shows the underutilization of some of these core measures, if you will. Less than 1 in 5 patients actually getting a statin when they have PAD as a form of preventative therapy for patients at risk. So this just shows that we need to do something before we get to this. So when do we call for help? This is a patient with some acute limb ischemia. We've got some elevation pallor here. We've also got, maybe even a thrombotic event in that 3rd digit. We've got dependent rubor. This is what I typically see in the clinic as I walk into the exam room, and you got patients with 1 red foot or both red feet. But some of the findings that we need to watch for. So some of our treatment targets, how do we know that we're doing a good job? LDL is the most commonly targeted one, but we've got some other markers that can be followed. I think those will be coming up in the conference later on today. This is another slide from our endocrinology colleagues with a really good layout of the different levels of risk. And what I wanted to impress upon folks is this newer category. It's about 2 years old now, the extreme risk category, where our LDL target is less than 55. So these are patients that you probably will see. I've got some in my practice, males under 55 who have had an event, or women under 65. So we do want to be really pretty stringent on these targets and actually go for them. This is a very busy slide. I would encourage you to go back and look at it later on. But this is a nice flow from the endocrinologist to see where and when different things get put in here. But the gist of it is pretty much everybody, well, yes, everybody gets lifestyle modifications, and pretty much everybody gets a high intensity statin. But we also look at adding in these others until we hit our treatment goal. And also, one of my favorite parts about this slide is it just lays out our agents in a very clear way with their doses there at the bottom. So please go back and look at that one afterward. It's also important to understand from a symptomatic standpoint, what are our patients' expectations, and also give them realistic scenarios. Want to talk about, hey, you might be able to walk farther and with less pain. It's also incredibly important to consider looking for a supervised exercise program if it's available to your patients. And then also just changes on physical exam. Some of the conversations you'll run into, I don't want you to feel like a salesperson when you're coaching your patients through this treatment, but you do have to advocate for them. Sometimes these folks have vices that obviously they're making poor health choices with their smoking and whatnot. And a lot of times it does require a bit more hand-holding to get the ball rolling. So the question being, well, what's my alternatives to starting a medicine? Because a lot of times we'll have patients that just want to wait and see, or they tell me, yeah, I'll work on that. I'll get back to you. Or we just go ahead and see one of the vascular specialists to help sort of corral and direct our decisions. But, something that is always helpful is the aggressive lifestyle changes. Again, a very dense slide, but got some really good information on here. You can find this quickly just by Googling the AACE 2020 guidelines, and pretty helpful. So here's the summary. Feel free to read it. It's got a couple of things in terms of the treatment agents that we want, but this is a serious problem. that's affecting a lot of our patients in our community, and it's something that really deserves our attention. So speaking of attention, thank you very much and enjoy the rest of the conference.